Assalamu alaikum everyone, and welcome back. Medic Level Up here, and I am back again with another video, and today's video is going to be about COVID-19, or the novel coronavirus, or the SARS-CoV-2. It does not have 19 points. Before we get started, let's bring up the lazy board, okay? So let's dive into the meat of it. Now, as we go through this video, all of this evidence, all of these studies, they are going to be a collection of the IDSA guidelines, the NIH guidelines, and the NICE guidelines. And there are some other articles that I picked up in order to make it more palatable for you guys, and in order to make it more rationale based for you guys. Now, in December in 2019, in the city of Wuhan in China, doctors discovered a new kind of respiratory illness which was caused by a virus which belonged to the family of coronaviruses. And since this was a new coronavirus, it was named as a novel coronavirus. This virus is actually the same virus that belongs to the family of the SARS and the MERS viruses. So the MERS was actually the Middle Eastern Respiratory Syndrome, and the SARS was actually the Severe Acute Respiratory Syndrome. Now, why is this disease called COVID-19? So it is coronavirus, and D is for disease, and then 19 because it was found out in 2019. Okay, so that's why the name COVID-19. In January 2020, the WHO declared this disease as an international health emergency, and was also declared a pandemic. Okay, so what exactly is COVID-19 and how does it present? What are the symptoms of the disease? Okay, so the Center of Disease Control and Prevention says that the disease has an incubation period of around 4 to 14 days, and 97.5% of patients are going to present with symptoms in the first 11.5 days. Now, what are the symptoms? So it can come with fever, shortness of breath, myalgias, cough, and a fatigue. Okay, so these are some of the constitutional symptoms of fever, and then majority of the symptoms are respiratory in origin. I'm going to post different percentages of all the symptoms in the lazy board. Now, at the time of this video, anosmia and agusia, which is the loss of sensation of smell and the loss of sensation of taste, has been anecdotally reported, and there is no strong evidence for it. Maybe in the coming trials, maybe in the coming studies, we will see these symptoms, but for now, it is only anecdotally reported. Viral shedding is highest in the symptomatic period because of all the coughing and the sneezing. There was a study done in China which showed that 44% of patients only had fever when they presented to the hospital, but 89% of patients over the course of their hospital admission, over the course of their hospital stay, they developed a fever. Now, I came across two different studies, one of which showed that the clinical progression of the disease is so that the median time to dyspnea is around 6 days in one study, and in another study it showed that the median time to dyspnea was around 8 days. So taking an average of around 5 to 8 days would be a safe thing to do. Okay, and the median time to the development of ARDS, which is acute respiratory distress syndrome, is around 8 to 10 days. And then a patient is usually admitted to the ICU over around 8 to 12 days. So that gives you a kind of an idea of how the disease progresses, and how early dyspnea develops, how early ARDS develops. But bear in mind that these are only median times. Of course, there are going to be outliers. Of course, there are going to be people who develop dyspnea earlier, who develop dyspnea later than usual, and there are going to be some variations. Let's talk about risk factors of the disease. I cannot really state all the percentages of the risk factors that are associated with increasing age, but I am going to post it on the lazy board for you guys to see. There was a study done which shows the mortality and the fact that it goes up with age. So it was stratified into groups with the people of less than 40 years old, and then 40 to 50, and 50 to 60, 60 to 70, 70 to 80, and then you can see that the mortality was highest in patients who were more than 80 years old. Another strong risk factor is the presence of comorbidities. So the majority of the mortality is going to happen when patients who are having some sort of ischemic heart disease or any cardiovascular disease. The percentages for these people was around 10.5%. For diabetics, it was around 7.3%. And then for every other chronic disease, such as asthma, any chronic lung disease, or hypertension, it was around 6% for each of these conditions. Now, if you look at the case fatality rate, the overall case fatality rate for this disease is around 2.3%. But if we take into account the severe disease, the critical disease, the patients who are going to get admitted to the ICU, it rises to a significantly high amount of 49%. Now, how do you actually diagnose SARS-CoV-2? So the go-to test nowadays is a reverse transcriptase polymerase chain reaction COVID-19 testing, which is the RT-PCR, which is usually available almost everywhere nowadays, and that is the go-to test right now. There are some ancillary studies that you can do if you are treating patients with COVID-19. These are CBC, CRP, D-dimers, ferritin, AST, ALT, LDH, and chest x-ray. And if you want to see the amount of lung involvement, you actually need to do a high-resolution CT scan of the chest. Now, when you're doing an HRCT, I actually came across a study which showed a severity score. So it is called a CTSS score. It is based on the amount of lobar involvement from COVID-19 pneumonia on an HRCT. What the radiologist does is that he calculates the lobar involvement and he assigns a number of points to that patient. Those number of points are out of a total of 40 points. Severe disease is indicated by around more than 26 to 29 points. Mild disease is indicated by around 11 to 13 points. So that basically gives you a stratification and an early clinical judgment tool in order to see where the patient is going, in order to see what kind of disease the patient has. Now, because of the fact that this disease is highly contagious, and I know that a lot of us are wearing our personal protective equipment, but still there are some guidelines in play which prevent the clinician or the doctor from actually examining the patient, and there are scales in order to make some diagnosis, make some remote diagnosis, such as the remote diagnosis of pneumonia. So the criteria for making the remote diagnosis of pneumonia is a temperature above 38, a heart rate above 100, a respiratory rate above 20, new confusion in the patient, and then you could also use the MRC dyspnea scale, which is the Medical Research Council dyspnea scale. Also, at this point, note that the CRB65 score has not been validated in COVID-19 pneumonia. Now, if you go over to the NICE guidelines, there is a separate chapter on how to manage the symptoms of COVID-19 at home. The first thing is fever, and it is indicated that you should use paracetamol. If the fever is not being controlled by paracetamol, you are supposed to use ibuprofen. I know that it is an NSAID, and we will discuss the controversy behind NSAIDs in this disease in a short time. The next symptom is cough, which is very bothering to patients, and the NICE guidelines recommend codeine linctus or codeine phosphate, which you can use to curb the cough. The third thing is the use of antibiotics. Now, as we know that this is a viral disease, and antibiotics are not going to be as effective as on a bacterial disease. So what they decided was that if you are going to use antibiotics, you need to actually keep a couple of things in mind. One of them is the fact that you need to assess the risk for C. diff colitis, and the fact that antibiotics can cause a range of side effects to the patient. If you are bent on giving him antibiotics, there are some set criteria you need to follow in order to be giving the patient antibiotics, and there are 3 of these. So the first one is when the cause is unclear for the pneumonia, whether it is a viral or a bacterial disease. When the cause is definitely bacterial, the second one, and the third one is whether the patient is too frail. Maybe he's too aged, maybe he has a state where he is immunocompromised, maybe he's a diabetic, maybe he's on steroids, any condition which can make the patient prone to a lot of complications. In that case, you are supposed to give him antibiotics. When it comes to what kind of antibiotics you want to give the patient, the NICE guidelines recommend the use of doxycycline. So it is 200 milligrams on day 1 and then 100 milligrams for the next 4 days. And if you think that the organism is susceptible, which is not the COVID, it is for bacterial. And if you think the organism is susceptible, make sure that you go for amoxicillin 500 milligrams 3 times a day for 5 days. Now let's talk about NSAIDs because we recently talked about using them to curb a fever. Where does this controversy stem from? On the 14th of March, the French Health Ministry raised concerns about 4 patients who were quite young, who did not have any comorbidities and who were suffering from COVID-19, they started using NSAIDs in order to curb their fever, and for some reason, for one reason or another, they developed some really severe and really critical symptoms from this disease. Now, after this, what happened was that they decided to collect 173 references, out of which around 13 of them were full text references. When they analyzed all those references, there was no conclusive evidence for the fact that NSAIDs cause a severe form of COVID-19. On the other hand, there is an RCT going on right now, which is assessing the use of naproxen in COVID-19. Now let's come to the other side, ACE inhibitors and ARBs. Now, I know there is a lot of concern about these two drugs, and it stems mainly from the fact that there is a theory and there is a hypothesis that the ACE inhibitors and the ARBs, they actually cause a upregulation inside the host for the ACE receptor. And if you know the pathophysiology of the COVID-19, the spike protein from the coronavirus is going to attach itself on the ACE receptor. So it makes sense. If there is a lot of ACE receptors, a lot of the virus is going to bind to the host cells, and we don't want that. But the thing is that they decided to pick up 2 retrospective cohort studies in order to study this, and there was no statistical evidence that using ARBs or ACE inhibitors causes a severe form of COVID-19. Now, at this point, while this video is being made, the American College of Cardiology, the American Heart Association, and the American Heart Failure Society recommend the use of ACE inhibitors and ARBs. When they're using it for another condition, they should continue using this. A similar theory was hypothesized for NSAIDs, and it showed that NSAIDs basically delay the recruitment of polymorphonuclear cells towards the site of inflammation, and then can cause a delay in mounting a host immune response towards the virus. So that's the theory behind why the NSAIDs, the ACE inhibitors, or the ARBs should not be used. But there is no conclusive evidence as to the fact that they cause a severe or a critical form of the disease. Now let's talk a little bit about reinfection. I know that everyone and a lot of people are panicking about the fact that the coronavirus can cause reinfection and that there are different strains of the virus. Well, that could be possible, but at this point in time, we do not have enough sufficient evidence in order to make that claim about the disease that it can cause a reinfection. Now, I have seen patients myself which present with a positive PCR test. They recover from the disease, and then they bring back a positive PCR again to my ED, showing me that they have the disease again, which is quite worrying for a lot of people. But at this point in time, there is no evidence which supports the fact that it can cause reinfection. The Korean CDC actually decided to take 273 patients who had recovered from the coronavirus, and they decided to do a PCR on them again. And a lot of people, a significant percentage of them, showed that the PCR was positive again. Now, this does not actively mean that they are suffering from a reinfection. For that kind of thing to be possible, we need to actually map the genome of both the strains of the virus and compare both of them to each other and see if both the strains are different in order to establish that it is in fact a reinfection. But right now, no evidence for that. Right. So let's talk about a couple of medications now. There is a medication nowadays which is hydroxychloroquine and chloroquine, which is being tested on COVID-19 patients on a trial basis to see whether this has a beneficial effect on the patients or not. Now, let me make this blunt and clear. Current evidence does not show improvement when chloroquine or hydroxychloroquine is used for patients with COVID-19. I came across a couple of studies, and I'm going to present some of those to you. Now, one of those studies was that they created a control group and a cases group, and what they did was that they decided to see whether there was any clinical improvement based on radiological findings and whether there was a quicker time to viral clearance in patients. So what happened was that there was no statistical benefit in the HCQ group. The p-value was around 2.11 for this study. The quality of this evidence was not too reliable because of 3 things. There was risk of bias, the sample size was too small, and there were a lot of co-interventions going on at the same time. Now, another study conducted was that there was two arms to COVID-19 patients. One of those arms was high-dose chloroquine, and the other arm was low-dose chloroquine. So what they did was that they decided to see the primary outcome at day 13 of the trial. Overall mortality was around 27.2% in both groups. The mortality was higher in the HCQ group, which was a higher dose, and 2 patients even suffered from ventricular tachycardia before dying. Now, the third study was between 2 groups. One of the group received only standard of care, and the other group received only HCQ along with the standard of care. So what happened was that there was no difference in the outcome of both those groups, and the fact that 30% of patients in the HCQ group suffered from side effects as compared to only 9% of patients suffering from adverse effects in the standard of care group. Right, so let's slowly transition into hydroxychloroquine and azithromycin working synergistically. There was a study in which they created 3 arms. One arm was receiving hydroxychloroquine, the second arm was receiving hydroxychloroquine and azithromycin, and then the third arm was receiving neither of these 2 drugs. So what happened was that the risk of death was the highest in the HCQ group, and this study is basically not peer reviewed, so that decreases the certainty of evidence even more. Another study was where these researchers used HCQ and azithromycin together in conjunction, and there were 3 cases where there was significant QT prolongation. It was also seen that 10 out of 95 patients had a QT prolongation of more than 500 milliseconds. A third thing I came across was that there are multiple case reports which show that azithromycin is basically developing VTAC and torsades in patients. So these are dangerous arrhythmias, and if you do want to use azithromycin, right now it is sanctioned for only use in the setting of a clinical trial, and even if you do use them, you should be continuously monitoring the patient's EKG. There was another study in which there was a treatment group with HCQ and azithromycin, and there was a non-treated group. It was seen that the hazard ratio from sudden cardiac death in the treated group was around 2.17 as compared to 0.85 in the non-treated group. Right, coming towards 2 other drugs, which are Lopinavir and Ritonavir. There was a study in which these 2 drugs were compared. There was Cow et al. Basically decided to randomize around 199 patients into 2 groups. One of them was going to receive standard of care alone, and the other one was going to receive standard of care plus Lopinavir and Ritonavir. Now, what happened was that there was a slightly lesser amount of clinical improvement failure in the patients who received Lopinavir and Ritonavir, but the p-value was still not significant. It was around 0.91. There was also noted that around 14% of patients were not able to complete the 14-day course, and they had to stop those courses because of significant side effects, which were mostly GI related. There was also a study which was done between 2 arms. One of them was chloroquine, and one of them was given Lopinavir and Ritonavir. At day 10 and day 14, both of these groups were assessed. At day 10, 90% of chloroquine patients had a negative PCR, and 75% of Lopinavir Ritonavir patients had a negative PCR. At day 14, 100% of chloroquine patients were discharged, and 50% of Lopinavir Ritonavir patients were discharged. Now, this sounds like very good evidence, but the thing is that the certainty of this evidence is extremely low. Let's look at why. So the study only had around 22 patients. Most of these patients were young, with a mean age of 41.5 versus 53 years. None of them had a lot of symptoms at the start of enrollment of the study. None of them had any comorbid conditions, and a lot of these patients were not critically ill. So take this evidence with a pinch of salt. Now, there is another drug which is Remdesivir, which has been studied a little bit. There are some trials, one of which is that the Remdesivir drug is actually decreasing the levels of SARS-CoV-2 in mice, but let's not talk about mice. There was a study, there are a lot of studies being conducted on Remdesivir at the moment, but the one that takes the light is the ACTT1 trial. It showed that patients who were given Remdesivir have a decreased duration of illness from a median of 15 days down to a median of 11 days, and the p-value for this was significant at less than 0.001. Now let's talk about steroids. Until recently, there was not enough data about steroids in order to use them in COVID-19 or not. So we had to rely on some of the data which we had previously stored from the SARS-CoV-1 and the MERS diseases. And until a while ago, it showed that steroids cause a delay in viral clearance. Now, recently, there was a recovery trial that gained the light and the attention of a lot of people, which showed that around 4,000 patients and 2,000 patients were spread into two groups. One of them was given dexamethasone and the other was given standard of care alone. And it showed very promising results. It showed the fact that around 1/3 of patients who were ventilated had a mortality benefit, and around 1/5 of patients who were using oxygen had a mortality benefit. So in easier terminology, out of 25 patients who are on oxygen, one of them is going to survive, and out of 8 patients who are ventilated, they are going to survive. Now this seems like very promising, and the p-value for this was significant either, but we still don't know how sound the study is because it's not peer reviewed. Maybe it has bias, maybe it has a flawed design. We'll see about this later. Now let's talk about interleukin inhibitors. There are two kinds of interleukin inhibitors. One is IL-1 inhibitors and the other is IL-6 inhibitors. Now you might not have heard about IL-1 inhibitors, but you sure have heard about IL-6 inhibitors, which is tocilizumab. There are two other drugs in this category, which is sarilumab and ciltuximab. Now there was a study done on around 63 patients which showed a good outcome, but the thing is that there was no control group in this study, which makes the certainty of this evidence a little low. When it comes to interleukin-1 inhibitors, the name of the drug was anakinra, and there was a study, it was a case series which was done on patients who received anakinra, but there was a historical control used to match the results of the cases and the controls, so the certainty of evidence decreases as well, even though it showed that anakinra does show some benefit to patients with COVID-19. Okay, let's talk about convalescent plasma. There is not enough evidence to support the use of it, okay? So what could be used in order to do benefit could actually result in harm for the patient. So let's go over the harmful effects of plasma first. When you actually transfuse convalescent plasma into a patient, you are actually predisposing this patient to antibody-mediated exacerbation of the infection, TRALI, which is transfusion-related acute lung injury, and then TAC-O, which is transfusion-associated cardiac overload, and then there is a very rare chance of red cell alloimmunization. Now let's go over the studies that were used in order to see whether convalescent plasma was working or not. Now these studies are going to be a bit more complicated, but let's stick together and I will try to make it as easier as possible to understand. Okay, so there was study A, which had around 4 patients, and then there was study B, which had around 20 patients. Let's come back to study B. These 20 patients were then sorted into two groups, which was 10 patients in the control and 10 patients in the cases. Now all these 10 patients over here, 3 of these 10 patients received convalescent plasma. Now what happened was that the person doing the study A decided that the fact that his sample size was too small, that he was going to take a historical sample size and he was going to match it with his own. So 5 patients there and 3 patients from this study B he took into his own study, and that creates around 8 patients in total. All these 8 patients received convalescent plasma. Now the thing is that 4 out of these 8 patients in study A were still continued on mechanical ventilation, and that is around 50% of patients for this 8 sample size, and these patients were continued on mechanical ventilation, which was considered as a surrogate, as a replacement for clinical failure. So there is still not a lot of evidence as to the use of convalescent plasma in patients with COVID-19. Now at the time of this video, there are not a lot of trials being conducted on ivermectin. The only literature that I was able to come across was the fact that there was one study that showed that ivermectin was actually inhibiting the growth of the virus in vitro, in viral, in H-SLAM cells. It was decreasing the concentration of the virus by around 5,000 times. But if you go over to clinicaltrials.gov right now, there are around 31 trials being conducted on ivermectin. So let's wait for the results of those. And there is also a study, an RCT being conducted in Pakistan somewhere as well. So watch out for the results of those RCTs. Now let's go over a couple of general principles for COVID-19. As for infection control, the current recommendation is to use a negative pressure room, so there is not a lot of aerosolization and the virus does not stay long in a room at the time. The second thing we need to talk about is hemodynamics. A conservative fluid strategy is preferred over a liberal fluid strategy, and there was a meta-analysis which showed that dynamic assessment to guide the giving the fluids to the patients is very beneficial in terms that it reduces mortality, it reduces the length of ICU stay, and it also reduces the need for mechanical ventilation. The dynamic assessment parameters were 3 in number, which was stroke volume variation, pulse pressure variation, and passive leg raise or a fluid challenge. Now the recommendation right now is to give the patient buffer crystalloids instead of colloids or crystalloids, and the guidelines nowadays recommend against the use of hydroxyethyl starches for IV replacement, against the use of dopamine if adrenaline is available, and against the use of dopamine in low doses, which was supposed to be for renal protection. That is no more. The guideline recommends for the use of adrenaline as the recommended vasopressor, recommends the use of dobutamine if there is evidence of cardiac dysfunction and persistent hypoperfusion, and recommends the use of corticosteroids if there is refractory shock. As for prone positioning, there was a study which showed 50 patients presenting to an emergency department in New York City, which had a median improvement in oxygen saturation upon prone positioning. There was a similar study done in China in which patients who presented with ARDS, 80% of these patients maintained an improved saturation upon resupination. So prone positioning is actually very effective in COVID-19 pneumonia or ARDS. You're not supposed to do prone positioning in patients who are hemodynamically unstable, who are in clear respiratory distress and need mechanical ventilation immediately, who have any abdominal surgery performed recently, and who have an unstable spine. The last thing we're going to talk about is oxygenation and ventilation. The target saturation of oxygen should be around 92 to 96%. If the patient is going into acute hypoxemia secondary to respiratory failure, try a trial of high flow nasal cannula as opposed to non-invasive positive pressure ventilation. If there is no indication for endotracheal intubation, go for non-invasive positive pressure ventilation for those whom HFNC, high flow nasal cannula, is not available. If a patient has persistent hypoxemia and you are not able to do an endotracheal intubation because it is not indicated, consider a trial of awake prone positioning. But bear in mind that awake prone positioning is not supposed to be considered a rescue therapy for patients who actually are in respiratory distress and have a clear indication for being intubated. This is based on non-COVID RCTs, and HFNC and non-invasive positive pressure ventilations actually have shown a statistical benefit in decreasing the need for escalation of ventilation or oxygenation therapy. Okay, so I am in my ED right now, and I am with my friend whose name is Atik. He is a respiratory therapist. He has worked in the ICU, he has worked in the ED with us, and he has a bachelor in emergency care. And if I am wrong about the ventilator settings, he's going to correct me because I am personally not an expert in ventilator settings, but that's why I've got him with me. So let's fire up this thing, okay? And we are going to go over the settings. So let's wait for this to start up. Okay, so what we're going to do is we're going to select a new patient, and let's make sure that the body weight of the patient is around 70 kg. We're going to set the mode to SIMV, which was synchronized, intermittent, mandatory ventilation. Okay, so that's why I'm not an expert. So we're going to hit continue, and we have all these fancy settings over here. So let's go over these settings one by one. The F over here is going to be the respiratory rate. The F is usually around 12 to 18. Am I right?
Yeah.
Okay, so it's around 12 to 18, but usually in ARDS, which is acute respiratory distress syndrome, we usually keep this around the high end. So let's keep it around 18. Okay, since we had a 70 kg man, the tidal volume is going to be set low which is going to be around 4 to 8 ml per kg. So calculating that, we have around 350 milliliters or of tidal volume. So let's adjust this. Okay, and then we're going to go to positive end expiratory pressure. Now the positive end expiratory pressure is normally going to be set at 5, but usually in ARDS patients we set it a little bit high. So what we're going to do is we're going to set it all the way up to 10. Is that okay?
It's combination of with peak pressure and
okay, perfect. Yeah, so we're going to combine this with the pressure support. Now the pressure support is usually around 12, and my friend Atik over here suggests that the pressure support plus the PEEP is going to make the plateau pressure. Now we know that the plateau pressure is supposed to be less than 30 centimeter of water. As you can see over here, it has this H2O. So this is set. Okay, and now let's go over to Vmax. Now the Vmax helps us adjust basically the inspiration to the expiration ratio, and we're going to set it around 1:2. Okay, that's it. Okay, so do we need to change anything else in this?
No, we can if the patient saturation is not
okay,
yes,
yes.
In these two things.
Okay, perfect. Okay, so the thing my friend is trying to say is the O2, the FiO2, you're supposed to titrate it to the
saturation
exactly to the saturation of the patient. So if the patient is saturating at around 90%, you don't really need to give him 100% oxygen. Just bring it down to like 80 or 60%. Okay. And if the patient has like really low saturation on his own, then you need to keep this all the way up to make sure that he's getting enough oxygen. The next thing is that the PEEP is basically needs to be titrated along with the blood pressure of the patient. You don't want to give him a lot of PEEP because that's going to increase the intrathoracic pressure, which is going to decrease the venous return, and it's going to decrease the cardiac output, which will result in hypotension. So did we get everything, or
the rest of the settings is according to the ABG's level?
Okay, yes.
If the patient have high carbon dioxide level, we can adjust according to their two things.
Okay.
One is frequency,
Okay.
respiratory rate, while the other is according to IE ratio. And RDS patient, we have two strategy. One, we have to watch out the carbon dioxide level, while the other is we have to keep the oxygen saturation level up to maximum. For the high carbon dioxide level, we have to do two things. Either we can watch out to increasing the respiratory rate of the patient, while the other is by adjusting the IE ratio. We can increase the IE ratio into 1:2. Normal is 1:2. We can increase into 1:3. While the other thing is that the most of the RDS patients have hypoxic. So we have to increase their peak and their FiO2. While the peak, mostly RDS patients have collapsed alveoli. So keep the alveoli recruited, and we have to keep their PEEP level high and low tidal volume, because in mostly there is a chance that the alveoli of the patient they can rupture, and so we have to keep the tidal volume low, high respiratory rate, high PEEP, and high FiO2. That's all, and thank you so much.
Now let's talk about antithrombotic therapy for COVID-19. At the time of this video, there is no evidence for or against the guidance of management decisions. If the patient is using antiplatelets or anticoagulant therapy, he should be continued on those. If a patient is being treated outside a hospital setting, there should not be any venous thromboembolism prophylaxis for that patient. If you do suspect thrombotic disease in a patient, you are supposed to screen for that in any other patient. The incidence of pulmonary embolism ranges from around 16.2% to 27%, even when there is thromboprophylaxis given to patients. The choice of anticoagulants supposed to be used is low molecular weight heparin or unfractionated heparin, because these have a lot less drug-drug interactions as compared to oral anticoagulants. If a patient is on warfarin, he should be using warfarin, since there is not enough data as to any contraindications of this. Thank you so much for watching this video. I know it was a lot of evidence. I know it was a lot to take in. The point of this video was to tell you what medication you're supposed to use, what medication are supposed to be used on a trial only basis, and what medication actually have a benefit. That's it for today. If you think I missed something, please do not hesitate to write that down in the comment section, and I would love some feedback from you guys. That's all for today. Thank you and have a good day.